Hello and welcome to this video on breaking bad news. Excuse me. I am Professor Anthony Cummins from the Department of Family Medicine at RCSI Perdana. I would urge students to also look at other elements in our breaking bad news section on the RCSI Perdana Family Medicine Moodle pages and read these in conjunction with this video for maximum benefit. This is the format of the video. We have some learning outcomes, a description or a question on what is bad news, and then looking at a structured way of breaking bad news, looking at reactions to bad news and how to deal with them, looking at patients' experiences of having bad news delivered to them, including particularly Dr. Kate Granger, who died in 2016, aged 34, from a rare sarcoma, but had written extensively about her situation in a blog. We look at the situation also where GPs often have to break bad news by telephone and not face-to-face. We look at a particular situation where the death is sudden and the breaking of that news is particularly challenging. We look at two scenarios for you to contemplate and play out in class. There's a summary sheet and some references for you. Having reviewed this video and read the ancillary information and documents on the Family Medicine Moodle pages, you should be able to identify and outline specific situations involving the breaking of bad news. You should be able to at least attempt to competently and compassionately deliver bad news to a patient. You'll get an opportunity to do this during some of your video consultation classes with simulated patients. You should be able to explain the necessity of providing support for doctors delivering bad news to patients. And finally, you should be able to outline the evidence behind communicating bad news in an appropriate and sensitive way. Bad news is basically any information that changes for the worse a patient and or a relative's or carer's view of their future and their concerns for the future. A good knowledge of your patient, especially in general practice and family medicine, because you may have seen them regularly for some years and may have known them since childhood, will give you a better understanding of their perception of the illness and their prior awareness of it. But breaking bad news, however well you know the patient, is particularly challenging. It depends on the scenario and the patient and literally does vary from person to person. However, these are not skills that are exclusive to general practitioners and psychiatrists. All doctors in all specialties, and often the surgical specialties, should be skilled in this area. How you break bad news to a patient and or family can have a huge impact on their perspective of their illness, their comprehension of what you've told them, their further relationship with you, and their satisfaction with the care you give them. There are two brief videos here showing good and poor examples of how to break bad news. So I would urge you now to pause this, watch each of those videos in turn, and then come back to this presentation. Before you do so, just reflect for a moment. Have you seen a healthcare professional, doctor or nurse, break bad news previously? Do you think this was done well or done poorly? And how would you have done it differently? Or how would you contemplate doing it differently now? Now, this is not meant to be an exhaustive list, and it's fair to say that all of these conditions can be serious and debilitating. So it does not mean that only MS and Parkinson's are, but each illness brings particular individual issues in its train. So multiple sclerosis and Parkinson's disease are inexorably progressive and are quite debilitating. And they strike at the most basic of things, one's identity, one's mobility, one's independence. The challenge of terminal illness is that there's the additional urgency about it with so little time left before the end of life. This is also true with motor neuron disease, another progressive condition for which there is no effective treatment. And even though there is treatment for heart failure, when somebody progresses to NYHA class 4, the likelihood of progression to death is very high, and it may be also very quick. Some illnesses lead to a particularly profound loss of function, such as brain attack or stroke, heart attack, acute myocardial infarction, and also, if, as often happens, heart attack brings in its train associated heart failure. Some conditions are initially not life-threatening or life-endangering, but they bring with them the potential for serious complications and consequences. I'm thinking here of type 2 diabetes mellitus and also of hypertension. Although all conditions impact on others, certain conditions have a direct impact on one's partner or wife or husband, such as infertility, erectile dysfunction, or sexually transmitted diseases. And although all of these are conditions that are vastly more common in adults than children, children themselves have severe illnesses that disrupt their lives, and the diagnosis of these and the diagnosis of their severity and their life-limiting qualities can be very challenging. So severe asthma, severe brittle type 1 diabetes, and severe epilepsy can be very disruptive to the life of a young child, leading to, at the very least, very disruptive educational attainment and so forth. And there are other conditions that may specifically impact directly and imminently on one's career. So a significant injury to a limb in a professional athlete, or the onset of a poor prognosis sarcoma in a lower limb, for example, in this setting, in a rugby player or footballer, is particularly distressing. Or a musician or taxi driver who develops epilepsy. This has huge implications for their career. Similarly, hand injury in a surgeon. Why do doctors find it difficult to give bad news? They may not be confident in doing so because they may have had lack of previous experience in doing it. They may not have had much training in doing this. They may be concerned about the patient's reaction to the news, and a lot of what passes for the relationship between the doctor and the patient is sometimes an avuncular, pleasant relationship, which can be very reassuring and comforting for the patient and for the doctor, but also has the double-edged aspect to it that it may make it difficult, it may inhibit one from delivering bad news honestly and consistently and sensitively to a patient. Some doctors feel that they are failing their patient by not curing them of the condition that they suffer from. And as in this avuncular relationship with the patient, they may want to protect the patient from distress. Because, especially in general practice of family medicine, the doctor may have known this patient and family for many years. In some instances, the doctor will have even delivered that patient as a baby, so may be very concerned about one's own emotional response to delivering such bad news. They may also feel that there is insufficient time to do this during the working day, or the doctor may feel that they lack sufficient information, particularly when dealing with rare conditions. You'll see later in the case of Dr. Kate Granger, she had a very rare sarcoma. There may be a fear of medical legal issues. What if the patient feels that the diagnosis was delayed through my fault? Will I be sued? Think about how you would feel if you had to deliver an unexpectedly negative result to a patient. You were not expecting to find a positive HIV test in this patient. Would you be confident to deliver this news? What would you find most difficult about giving this bad news? Let's look at a structured way of delivering bad news, often referred to as spikes. This talks about setup, perception, invitation, otherwise referred to as information, knowledge, emotion, otherwise referred to as empathy, and summary, including follow-up. This is actually a reference to the oncologist, where this system of delivering bad news is dealt with in more detail. You can click on this later and see the full text paper. So let's look first at the first S in Spike's setup. It's all in the preparation. Be prepared. Know all the facts. Read all the notes and letters. It is galling for a patient, having been summoned to a doctor's office to get the bad news of a new diagnosis which they are fearing, to find out the doctor hasn't read the information, hasn't got the reports, and they feel let down by this. If you need to, in advance of seeing the patient, clarify the results by speaking with lab staff or radiologists, etc. Ensure that the room is quiet, seating is comfortable, there are tissues available if you perceive that this patient may be distressed and tearful. And make sure also that there's adequate time available. If need be, book a double appointment, or at the end of surgery, or a time when you'll not be rushed. Minimize the chance of the patient being kept waiting for a prolonged period. This is very distressing. Try to organize that you will not be disturbed. Tell your practice manager, your nursing and doctor colleagues, please do not disturb you during this time and that time. Turn off the phone. This is always should say off. And advise staff that you will be with patient so-and-so, you are not to be disturbed. Also suggest to the patient that they might prefer to bring their husband or wife or somebody important to them to this consultation. That lets them know in advance that this is going to be an important conversation. Before you tell anything, ask appropriate questions to gauge how much the patient already knows. How are you getting on? I've asked you to come in today to discuss your results. Can you remind me of what happened so far? You may refer to when this investigation, for example, was done at the local hospital, and ask, were you given any information about your results when the test was being done? Be aware also of non-verbal communication skills. Even though the patient may not say anything, you may deduce from their behavior that they're distressed or they're holding something back. Don't interrupt. Listen. A great complaint by patients of us is that we interfere far too quickly, and it's reckoned that the average GP, even when giving bad news, may interrupt a patient within about 16 to 20 seconds. Listen and let the patient tell you. They may disclose how much they understand. They may, the language that they use and the ideas and concerns that they have about this condition. Summarize what you've already discussed and reflect that back to the patient, what she has told you, so that you both are clear what has been discussed. It also shows them that you are respecting them, that you've listened carefully to what they've said, and you also give them an opportunity to correct you if you have misunderstood. Check whether the patient wants more information by asking something like, would you like me to discuss your results with you? Some patients will not want information at this point, but if so, you can offer to discuss it with them when they are ready. But again, make sure you set up an organized time, a definite time for this, again with all the same preparation as in step 1. Phones off, protected time, staff aware, etc. This is when you now give information. You give what's called a warning shot, by saying something like, I'm very sorry, but I have some bad news for you today. And use a language that's appropriate for the patient. Some patients, because of their different intellectual background, they may come from another country, they may not know the English language well, for example, they may have limited educational background and so forth. And if you know these patients, you can judge the level of language and the appropriateness of the language to use for this conversation. Try not to use technical jargon. Try not to be excessively blunt, and allow them to ask questions, or not to if they prefer. Silence can be very important here, and sometimes doctors are very uncomfortable around silence and they feel they have to fill the void with speech. You don't need to do this. It often affords the patient an opportunity to say what they feel. Make sure you offer further contact, a further follow-up appointment to discuss what has been already given, either the result of the diagnosis, when they feel able to do so. You may give them your number for them to WhatsApp you. You may ask them to ring the clinic or whatever method seems most appropriate. Emotions or empathy. This is probably the most difficult part of this whole conversation. It's the challenge of responding to the patient's own emotional response to receiving the bad news. Allow them to talk about this. It gives you an idea of how you will need to respond. Allow them to speak. Be prepared to listen. Try not to give false reassurance. Do not lie. Do not facilely say that everything will be fine. Do not say that. You try to understand here how this person is feeling. You must allow time for the information to be processed and for the person to react to it. Even though you feel they've understood everything you've said, most patients' experiences when receiving bad news is that as soon as they hear the bad word, be it heart failure or cancer, they close off. They go numb. They hear nothing else. They only hear that word, that cancer word. That's all they hear. You should be aware of this, and this would inform how you would deal with the patient's response. You should then summarize and plan a definitive follow-up. Having a definite plan helps them to become less anxious about the situation. It would also, by sharing the decision-making, gives us some control back to the patient at the time when they feel particularly helpless. Offer a follow-up appointment in your clinic or a telephone call or both. The patient will process some, but maybe not all of the information you've just discussed in your clinic right now. And they may recollect only some of it later and perhaps inaccurately. And that's very understandable given the level of stress they are under. So it's very important for them to have the opportunity to come back and see you and to be able to contact you at short notice to discuss it. Think also of practical issues. Does this person live alone? Are they going home to an empty house? Do they have somebody who supports them they can talk to, a confidant, for example? Remember also, for your own protection, you may need to debrief with a colleague to acknowledge that this is a difficult situation for you as the doctor giving this bad news. Dealing with death and dying is a cause of severe stress and often burnout in health professionals, so please look after yourself as well as looking after your patient. What potential reactions may there be to bad news? Well, these are very varied. Chief among them probably is numbness, a complete acceptance but no apparent emotional reaction. This is where there's like a cone of silence. It's a deafening silence, and the patient has heard no other word other than the one word, cancer. There may be disbelief. Surely not, doctor. Are you sure that's my result? Is that somebody else's result? They can be very distressed. They may be very angry, and this anger may be directed at you. You must interpret this in the light of the information they've just been given. They may feel very guilty. Let's say a man who develops lung cancer may feel guilty of the years of smoking and feel ashamed and feel a responsibility to his wife or his children that he's brought this on himself. There may be self-recrimination. There may also be an acceptance, and some people adopt a spiritual acceptance of what has arisen and are resigned to it. Many of these reactions are very similar to what we experience in acute grief or bereavement reaction. They may also feel hopeless. They may feel very confused. They may feel that the situation is out of their control. So it's so important that we have you as an ally and a confidant and a supporter. And it's doubly important, therefore, that you allow them time to reflect and to come back and see you again. But are there experiences of having bad news delivered? You can't just give somebody high quality of information, but lacking in emotional support or vice versa. Patients have a right to expect empathy and good information quality, no matter how bad the news. Let's reflect briefly on the life of Dr. Kate Granger, who was born in 1981 and died in 2016, aged 34. She was a geriatrician in Leeds and suffered from a rare sarcoma called a desmoplastic small round cell tumor. And she wrote extensively about her experiences of being given bad news in her blog, which you have a link to here, and about her journey through this illness. She was awarded Fellowship of the RCP for her work and her campaigning to improve the quality of care in the health system. And specifically, she launched a campaign on Twitter initially, #HelloMyNameIs, advocating that all healthcare workers should introduce themselves by name to patients. You can also see a link here to the life of Kate Granger from Wikipedia. This is an excerpt from her blog, The Other Side. I'll read this out to you. The third day of admission brings me some examples of doctors' communication skills being the worst I could ever possibly imagine under the most painful of circumstances. I know that my MRI report was available, but no one has taken the time to discuss it with me, so I know now it must be bad news. I'm laid in a hospital bed, sobbing and scared, about the most vulnerable a patient could be. A middle-aged woman wearing a headscarf breezes into my room without knocking. She announces her unpronounceable name. She does not wear a name badge. She says she's a gynecology registrar. She then says something that I still cannot fully comprehend to this day. She asks me why I'm so upset, to which I respond, well, because I'm 29 years old and I've got cancer. Her astonishing reply is, don't be silly, this won't turn out to be cancer, you're too young, it'll be something benign. Later that morning, a young gynecology senior house officer, whom I have never met, sits down next to me and out of the blue, after a cursory introduction, tells me, oh, your MRI shows evidence of spread. I'm quite astounded by the lack of quality communication given the circumstances. Sometimes GPs need to break bad news by telephone, and this brings its own challenges. Now, it is not ideal to do this, but sometimes it does arise, where an outpatient test result, for example, indicates significant findings. Generally, it is best to ask your staff to make an appointment with the patient to come into the clinic to discuss the results, but often this is not possible. Alternatively, a home visit may be more appropriate. This is more easily done in Ireland and the UK than in Malaysia, where home visiting is not generally part of the healthcare system. Be aware also that a report may come in of an abnormal result, particularly a significantly abnormal result, but you may not have ordered that test. It may have been ordered by a colleague. And you may not have any prior knowledge of or any relationship with the patient. Even though the situation is far from ideal, try to adhere to the SPIKES framework as much as possible when delivering bad news by telephone. So again, be prepared for this call. Check, is this the right patient? Confirm that with the patient. Ask if they can talk. For example, they may be driving or otherwise distracted. They might be at work. Identify yourself and your clinic address to confirm you are who you say you are and this is the right patient. Ask also if there's somebody else there with them to support the patient. Does your patient know why you are ringing? Ask about the circumstances of the investigation. Ask about any concerns or worries he or she may have. Tell them that you have the results and ask if they would prefer to come into the clinic to get the results face to face, or are they happy to receive them over the telephone? If they are, then offer a warning shot like, well, these results were not what I was expecting, and there appears to be a problem that will need to be addressed. If agreeable, give the results over the phone, and give the information in chunks, little bits at a time, and allow a pause and silence for reflection and thought Be honest and sensitive. You may have to repeat the news. Check that they understand what has been said. Offer to stay on the phone for so long as he or she needs. Ask if he or she is okay. Again, allow silence. And say you are sorry to have to give this bad news. In summary, again, give your contact details. Offer to see the patient in clinic next day or arrange a home visit. Make sure when you do see them you are undisturbed. Ask them to bring a family member or partner. Giving bad news in certain circumstances can be particularly challenging, and we're thinking here about bad news around sudden death. For example, if you become aware of the sudden death of a patient in your practice, you should inform the staff and any other healthcare professionals of the event so that contacts with the family can be sensitively handled. Make a note of the sudden death in the medical records of family members so that if they also come into the practice to remind staff or inform locum GPs in your practice of the connection. It is very upsetting for family members recently bereaved to come to their clinic and find that the doctor seems to know nothing about the death of their mother, for example. Find out what the family or next of kin already know and try to fill in the details if you can. Always give accurate and reliable information. Answer questions honestly. Even if the answer is, I don't know that yet. Remember that consent from next of kin is not required for a coroner's post-mortem in the UK should it be requested, and this can occasionally cause distress to the family. Or for follow-up contact to the family members. We now have two scenarios here for you to role play. The first one is of Mrs. Rita Lee from Kuala Lumpur. She's age 45 and married. She's attended your clinic since childhood. She presented recently with a breast lump and was referred for a triple assessment, which confirmed a breast cancer diagnosis. She has just received the results from the breast clinic and has come into your clinic as her GP to discuss them. She's devastated. Her primary concerns are about the welfare of her two young children, the youngest of whom both are still at primary school. You have a letter from the team that informs you that her bone scan has shown metastasis, about which Mrs. Lee seems unaware. Think about how you would approach and conduct this consultation. Which factors do you think are important here? Let's look at scenario 2. Nurul Najwa is age 28 and has been attending your practice for a couple of months with a symmetrical polyarthropathy. This is affecting her hands, her wrists, and her proximal interphalangeal joints. Initial blood tests showed a very raised ESR and a strongly positive rheumatoid factor, and plain radiography showed erosive changes in the small joints of both hands. You are aware that her mother has had multiple joint replacements as a result of the onset of rheumatoid in her 20s. You strongly suspect that Nurul Najwa has new onset rheumatoid arthritis. She's due in today for the results and for you to discuss the likely diagnosis and the next steps. You're hoping to have her seen at HKL's Rapid Access Rheumatoid Clinic tomorrow. Think about how you would approach and conduct this consultation and which factors do you think are important here. Here are some references for you from hospice-friendly hospitals. There's also a very excellent section on breaking bad news from one of the UK GP training networks, looking at doctors' responses and poor communication in simulated bad news consultations, looking at breaking bad news from the patient's viewpoint, and a further article from American Family Physician. There's also another reference that I haven't put up here. It's a website called healthtalk.org, healthtalk.org. It has a wide range of video and MP3 and text accounts of real patients' experiences of having bad news broken to them as part of the National Health Service in the UK. Thank you.